Bone-targeted therapy for a newly diagnosed patient with metastatic disease is a little bit controversial. There have been studies done both in the US and in the UK with zoledronic acid. The UK study, which was recently reported, actually seemed to suggest that there may be a potential benefit. It's a little controversial because in one UK study that looked at zoledronic acid, there was no benefit, but one that was done recently, published recently, which looked at zoledronic acid plus celecoxib, seemed to suggest that there is a benefit. So we're waiting for sort of confirmation on that point. In the US, zoledronic acid was not shown to lead to a significant disease control benefit or a survival benefit when added to early hormonal therapy. So for the most part, in these cases, I'm not using a bone-targeted therapy. If a patient has a bony event, a fracture, a spinal cord compression, or some type of a very clinically significant bony event where they may be at risk for continued bony events, I would be more likely to use it earlier in the clinical course. But for a standard patient who has bone metastasis that are not symptomatic and there's not been a bony event, I think it's reasonable to not use a skeletal targeted therapy.